Well, now we can go to objective two. How can we diagnose or treat brain injury in this population? So let's evaluate some brain-based diagnostic screening tools, rehab strategies, and target some improvements for increasing our behavioral outcomes. Uh, to make this really simple and sort of a metaphor, there now exists a blue tent in professional football, particularly to diagnose brain injury. We all know these guys go in the blue tent and they're able to play or not, and they're using some very interesting things to do that. Let's use those tools already developed in professional sports to apply to individuals in the justice system. Let's make sure that they can have better outcomes in their games of life and be able to return to play. So let's apply this neuroscience developed by millions of dollars to the Department of Defense, college and professional athletes, to this population we serve in the justice system. I'd like to start with Micki Collins. Micki started the very first concussion outreach and clinic at Pittsburgh. I think you really enjoyed this. I have somebody here in the audience that's going to wear some simulation concussion glasses and describe how they feel when we're done. So here we go with Micki. Micki?
And so what concussion is a mismatch between demand and supply of energy to the cell. Now, this is not enough to cause cell death, Wallerian degeneration. There's no structural changes to the neuron. There's no death of the neuron, but the cells struggle to operate at their normal efficiency. And we've now learned that when that energy problem happens, different systems in the brain can be decompensated. And that decompensation of certain systems, we've now learned there's different types of concussions. There's actually 6 different types of problems we see following concussion. And those different types of concussions help to determine how we treat the problem. So as a clinician, my job is to find out where the aberrant signal is coming from and what system is decompensated. And then we have to apply the right treatment to the right problem. None of anything I just told you we knew in 2000, none of it. And so we've now really learned a lot about how this injury occurs. We understand the pathophysiology fairly well, not completely well. There's animal model work that's been looked at with that. And more importantly, we now clinically know how to evaluate this injury in a way where we can kind of figure out what's happening and then apply a more targeted treatment.
So that's the whole thing, to be able to diagnose accurately and a targeted treatment. And I'm going to let you describe, taking those glasses off, what you're feeling. A lot of times people can't really describe what goes on during a concussion. They just know something's wrong. And he talks about the subtypes: vestibular, oculomotor, eye movements, cognitive processing, migraine, and anxiety and mood, as we're talking about today, and that was also associated sleep and changes with the neck, cervical. Isn't it amazing that some people transition from just a social drinking to alcohol or behavioral, what I call running through behavioral yellow lights instead of behavioral red lights? And these are all, these transitions to addiction or faulty interloops that we have that has to do with escalating use and loss of control, or this prefrontal dysfunction. I thought this would be very helpful when you think about concussion in this format. Back to Micki.
But there's really no, like, you hit your head this way, you have this problem. Rather, Peter, and this is important, concussion fights dirty. Like, whatever you bring to the table that's weak seems to be affected more generally in patients. In other words, there's pre-existing risk factors to have a worse outcome from this injury that will probably be quite surprising to hear for people. And not only those risk factors not only put you at more risk for less force causing concussion, but they tell you what kind of concussion you're likely to have if you do have a concussion. For example, we talked about the different types of concussions. If you have a history of car sickness in your past, we've published a lot of data showing that those patients are more likely to get concussed and have a vestibular problem following concussion. If you have a history of lazy...
Sorry, just to make sure I understand that.
Yep.
They're more likely to get concussed, or if they get concussed, they're more likely to have vestibular symptoms. Is it both?
Both.
Okay.
Correct. Less force will cause injury in those patients.
Wow.
Patients that have history of migraine, less force causes injury, and and you're going to go down that migraine pathway. If you have a history of lazy eye or strabismus, um, you're going to go down the ocular pathway. And yes, less
Wow.
force causes injury. If you have a history of anxiety, you're going to go down that pathway more ubiquitously. But there's
So you get an idea of when we talk about concussion fights dirty, as we think about it, with the cognitive demands, particularly in the behavioral side, uh, any behavioral mood tendency becomes more and more pronounced, and those individuals with, again, adverse childhood experiences or other limited prosocial emotions, uh, it's easy to understand why that would lead them into criminality, where some people do not. I'd like to introduce you now to a friend, Dr. Jam Gajar, board certified neurosurgeon, made really a mark in the United States with the Brain Trauma Foundation, which he founded, and particularly establishing guidelines for severe brain injury. Was able to share that after a horrific problem in Central Park a number of years ago, that rape, and was able to use his guidelines to change behavior. So if you have a car accident today, all from the ambulance to the ICU, his foundation's guidelines will save your life. Now, about 15, 20 years ago, Jam came to Stanford and did the same thing for TBI. And so, even though he wasn't able to come today, he was going to be my co-author. He was able to film this for us. Back to Jam.
Hi, my name is Jam Gajar. I'm a neurosurgeon, founder of the Brain Trauma Foundation, and also NeuroSync. As founder and president of the Brain Trauma Foundation, we do the national guidelines for traumatic brain injury. And when those best practice guidelines are put into place, the death rates drop by 50%, and the outcome of patients with traumatic brain injury has improved a lot. One of the issues in traumatic brain injury is mild traumatic brain injury, or concussion, and we're funded by Department of Defense. Not only do guidelines for people with severe traumatic brain injury, but also for mild. And we were asked to define the condition. And unfortunately, there's like 32 different definitions for mild traumatic brain injury. And so we went into in depth and found evidence to support subtypes. There are certain things that people with concussions have that are common, and we call them subtypes, and we can measure them, and we also can correct them. And a lot of them have to do with attention. So when somebody gets a concussion, what happens is they have attention problems. They can't pay attention. They're at risk for injury and risk for not only head injury, but other kinds of injuries, and can't perform. And so those attention metrics we took and funded by Department of Defense, we did large clinical trials using eye movements to look at how well we can measure attention. Now, eye movements are very particular because everything has to land on your fovea, the back of your eye. You put your thumb out, all you can see is your thumbnail, and that's all you can really process. Your brain can process. It can't process the whole world at once. So when it starts to move, your brain has to pay attention and predict where it's going to be. That prediction and attention can be measured very accurately, very quickly, and it's a measure of attention. And attention is really inhibitory control, which I know a lot of you are there at the conference for juveniles and individuals who are in the justice system. And a lot of those individuals have trouble with inhibitory control or paying attention, and may lead often to their circumstances. And so we've been measuring it over 100,000 individuals. We did large clinical trials of children and adults, concussion, ADHD, sleep deprivation. And each one of those had a signal in the eye movement so you can pick up and measure how well people are paying attention within 30 seconds. A very quick test, very accurate, very reproducible. And the good news is it's treatable. When people have trouble with inhibitory control, you can train them to improve that. And so I'm really happy that you all are meeting and discussing this. And I think in the future, we'll be able to measure individuals in the justice system to see if they have these problems and try and correct them. So thank you.
And so I appreciate Jam's involvement. And you might say, well, that's sort of interesting, eye movements, but hey, we already use eye movements. You know, if you get pulled over from the side of the road for a DUI, eye movements is really only one of the few things that can be used for evidence in the court. Just like again, concussion glasses, drunk glasses. And then maybe many of you are involved with EMDR treatments, the treatment of just eye movements associated with dealing with post-traumatic stress, particularly if it's just one single event, become very effective. So yeah, eye movements are just powerful, and we're talking that they're powerful diagnoses. And as Jam said, really the problem with a brain injury is prediction deficits. And when there's a prediction deficit, your spatial temporal disorientation becomes disoriented. And that triggers a sequel of other disorders, including cognitive and anxiety mood problems. And Jam would say, appreciate for these slides he let me use, the brain has a hard time. It's impossible to be in present because neurons take time to fire and propagate. So we have to be in sync with our world, we have to have predicted timing. So a tremendous amount of brain real estate is in a feed-forward future to help us know what to do next, as again, and we think in tennis. So our brain, you're constantly predicting the future, but you break into the present, you inhibit into a present to experience then what's become the past. So we have to be synchronized with our horizon of interaction in this world. And a disruption of this concussion, this prediction happens during concussion, and that loss of inhibition would affect prosocial functioning. So obviously that affects what we're talking about here in the conference. Predictive brain state changes the rate of how we process things in our anticipatory neuroactivity. So this is the way I look at it. A poor, inaccurate prediction of our current timing or situation leads to anxiety. A negative prediction of what would happen in the future after a number of problems leads to something we call depression. I think it's a very therapeutic way of thinking about what we go through. And a lot of times people think that, wow, the problem with concussion, they're hyperactive. They have a problem. No, actually, it's the braking problem. And so with eye movements, what will happen after a concussion is that instead of staying right on target, you'll see there's a little target that the eyes are following. You're actually seeing the eyes, what they do in real time, they jump ahead. In other words, the braking system is messed. The prediction system that's supposed to slow them down and keep them right along the interaction causes a high amounts of variance, and this becomes an extremely effective biomarker for prediction and inhibition. So here's some of the methods that Jam used with a normal individual. Again, the eyes focus really closely, but the main thing is this jumping ahead is just so important to understand this predictive impairment. And Jam has just elegantly put this to mathematics. So here's something, instead of self-reporting, here we have some really strong mathematics, which he has tested over 100,000 people. That has to do with error. And the biggest benefit, of course, is a smooth pursuit, which helps us understand the spatial changes. But with the variability, higher variability, the less predictive value. And so here we have this wonderful tool that can go ahead and measure after concussion. And then we can also see recovery rates also when someone is better, because a lot of times they don't really know how much better they are. So here we have this wonderful window to the soul, and particularly in what we do, what is an amazing, we have a direct measure of disinhibition. Wouldn't it be a great number to know how much control this person can actually do neurologically, not just guess that they're being a troublemaker? So of course this leads us to let's apply these Stanford these protocols that we're using at the Stanford Performance Center into corrections, and we're starting to do the assessments. Here's an example of an assessment using Jam's iSync technology. A woman comes in, she's 30 to 35. very motion sensitive. When we ask her to cross her eyes, it's very, very painful. Interesting enough, regular eye movements are originally pretty good, but as we measure how well she does as she moves her head back and forth, these graphs are supposed to be just a pinpoint. Her eyes move all over the place. Anxiety level through the roof. History of multiple brain injury. She is in difficult situations and literally hard to even be able to manage the system there. I went back to Washington for an advocacy for brain injury, and a group asked me to try out their instrument. This is from rugby players, something called iGuide, and I thought this was very interesting. This is just a regular sampling of 5 women that were brought to my office at the same time, and so we checked them all out. This test takes literally 10 seconds. This first individual, college educated, absolutely, no problem at all. She said she had behavioral health issues, but no direct brain issues. Did very well. And then here's the other 4. This is sort of how it's set up. This is the sort of the ratio. And these women had extremely poor inabilities to move their eyes, as you can see here. This woman in particular, she initially denied having any problems. It's fascinating how many people say they don't. And then she finally admitted, about a year ago, a group of men were mad at her husband and beat her to the pulp. She had to go to the hospital, coma. Yet, again, that retro amnesia, she wants to forget. Another tool that we use, just to give you a breadth of how many tools are out there, right eye. I use this for my college athletes. And so this measures some really direct ways of accuracy with a different algorithm where your eyes target as they track and as they team. Here's another one that's from the Pittsburgh, actually Philadelphia group, CHOP, something called iBox. Interesting note, just last month, LA Court motion included iBox as a expert witness. So you're going to see this more and more, whether you like it or not. You're going to have more and more people that have had this type of testing, and they're using it in a court system to help guide jury decisions. Here's the exciting thing. The new Orion glasses that are coming out through Meta, less than $600. We're going to be able to now no longer have an instrument. It'll all just be a pair of glasses you put on, and these assessments, as well as a lot of the treatments, will be available. So accessible. Here's sort of the interesting thing. As an old guy, we recognized this way back in the 1980s. When I was asked to be the principal investigator for a study at the Youth Authority, we found out that in El Paso de Robles there was a youth authority of 1,600 boys that needed to do something. We incarcerate all these children. And so at the time, literacy was a big thing. So we used this Visograph machine along with an Apple IIe computer, and we measured eye movements. And guess what we found? After doing some work, we were able to increase their reading scores. Literacy was the big thing at that time. And particularly their reading rate from 160 words to over 300 in our treatment group. Very successful, again, using eye tracking. And of course, my big aha moment was, guess what? We were really measuring brain injury. Now, you don't need all that fancy stuff. The VALMS test, which you can easily learn or treat, and I'm going to give you an abbreviated version of that, is something that the military has put together. Easy for you to make some easy assessments to do the same thing, except not with an eye tracker. So we're going to give you the tools. Stick with us. And one thing about I love DSM, but surveys and self-reporting is that as accurate as repeatable objective testing. I'm suggesting that, boy, here's this extra tool that we can add to the DSM manual. And so again, just going over those trajectories, now we have the ability to find and we can establish some protocols for instead of back to learn, maybe back to treatment, back to parole standards for our gender, our population. And of course, each subtype has its own set of symptoms recording. You'll notice a lot of overlap in these symptoms. A lot of times individuals really don't know what's going on. And you look at the anxiety mood, isn't this all Uh, all this is associated with what we deal with in the mental health arena. And then the other, just that general feeling bad and fatigue. And again, very hard to put your name on it. And as Jam said, now we have the ability to target those treatments based on the concussion subtypes. And this is beyond what we're talking about today, but under the migraine type, here we got these things that we can do, psychology, psychiatry, and work on their sleep as a way of helping these individuals. And to just sort of end this idea of, neuroplasticity. And remember, children are even more susceptible. But with justice involvement, you can have a positive feedback loop, as we should do, as we learn language and many, many things, learn to dance or whatever. But unfortunately, these individuals have this negative feedback loop as the reward systems are hijacked to risk and risk-taking behavior and even criminality. So, of course, my goal is to make sure that eventually we have TBI as a part of our guidelines. When you go into a jail, we're hoping that our people that are trained will be trained with guidelines associated with TBI, not just diabetes or the other things we go through. And this is an ending statement from Micki.
There's a lot of misinformation out there about concussion, and I think it actually hurts outcomes a lot of times. Clinicians that aren't aware of the recent advances in knowing how to treat this, clinicians that don't know how to do the right evaluation. And there's a lot of mismanagement and mistreatment of this injury that leads to very poor outcomes. Again, and you're going to hear it from me over and over again, if you bring me a patient with concussion, I can pretty much tell you I can treat that and get that patient better and get them back to the sports they love. There are highly effective treatments with this injury.
So just to amen to that, as somebody that also has treated college and high school related and weekly treat brain injury from all different sorts. When I really had my aha moment, actually with a man that was my age that had no problem, just had 2 brain injuries and then ended up in jail because he was out of control. It was really eye-opening to me that we need to help this population. So our next portion will be actually applying those very important aspects.